going to, yeah. So welcome everyone to this Afrika Nå seminar that we have called Corona Vaccine Access and Vaccine Equity in African Countries. So it's quite a broad topic. We'll not be able to discuss everything related to this today, but we'll give it a very good shot. The discussions regarding the effects of the pandemic are countless, and they will continue for years as it becomes clear what kind of effects this global crisis has had on all aspects of society. Many African leaders have voiced their concern over what they call vaccine nationalism, and this is not without reason. The EU, United States, and Canada have hoarded the vaccine, some say, pre-purchasing doses for up to 6 times their population in some cases. Mm-hmm. And the same countries are also buying the vaccines at preferential prices because of national agreements with the pharmaceutical companies. India and South Africa have asked the World Trade Organization to waive intellectual property rights, so manufacturers in those countries could fill the gap in production capacity, and they were denied. And Norway was actually one of the countries who voted against this. So this is the situation that we're seeing in the international scene right now. Luckily, we have a very capable panel that will guide us through the situation on the ground right now in regards to vaccine access, what the plan is moving forward, and also address the unfair distribution of vaccines in the global south. So we'll first hear the introduction from our 3 panelists. But you can already now start sending in your questions. Kindly use the chat function or the Q&A function, and we'll get back to your questions as we move along. We have an hour and a half for the whole program. So with us this afternoon, we have, one in Harare, Dr. Meseret Shibeshi. She's the immunization systems focal person for World Health Organization's regional office for Africa's inter-country support team for East and Southern Africa. So hi, Meseret in Harare. We have Peter Hangoma. He is a postdoctoral researcher at CMI and the University of Bergen, where he evaluates the impact of health interventions and benefit packages on welfare, financial risk protection, equity, and health status in Ethiopia, Zanzibar, and Malawi. And Peter, you're with us from Lusaka. Hello?
Yes.
And then we also have Salome Maswime. She is an associate professor at the University of Cape Town. She's an obstetrician and gynecologist and the president of the South African Clinician Scientist Society. So Salome is with us from Cape Town. Hi, Salome. The order of the panelists, I think we'll start with you, Meseret, then followed by you, Peter, and then lastly, we'll give the word to you, Salome.
Okay.
So Meseret, you can go ahead, just share your screen and you can start your presentation.
Thank you. Okay, can you confirm you see it?
Yeah.
Presentation, excellent, thank you. All right, so I will be dealing with the vaccine introductions, and this is the outline I will be using for the sake of time. The global state of vaccines, where are we? As at 2 days back, this is where we are globally. We have 104 days has passed since first country started vaccinating. That is 22 days also since the first use of the COVAX doses. And I'll come to the COVAX soon. Over 458 million doses have been administered, but majority in the developing world. And you could see on the right side of the slide, you could see Israel, United Arab Emirates, Chile, the United States are leading the vaccine per 100 people of their population as of March 2021. But low-income countries, as you could see here, mainly in Africa, are not yet advancing in vaccination. So we'll go through the details. There is globally ACT accelerated goal aiming to reduce mortality and severe disease through the accelerated development of vaccines, diagnostics, as well as therapeutics. So these, for the vaccine specifically, we are going to see how the COVAX facility came into play. And the aim is to really strengthen the health system in the meantime by protecting health systems and restoring economies. In Africa, when we come in, I just want to show you, sorry for the crowded slides, but I'll walk you through. What did we learn from past vaccine introductions in Africa? We had the 2009 H1N1 pandemic, maybe most of you would remember. And look, Africa was sharing the burden of the disproportionate deaths, even at that time. And then the vaccine distribution, it came very late. However, population coverage also has been achieved, though it came late. On the left, you see the pneumococcal vaccine introduction at a slow pace all the time. And also the exacerbation of Ebola still. During conflict, we have still managed. So Africa has lots of lessons that are being learned from vaccine introductions, but we have lagged behind in accessing new vaccines. The cost has been the main major driver for delay for our countries, and we are limited with experience in adult vaccination. Only few countries like South Africa, Seychelles, Mauritius, who are used to vaccinate influenza vaccines. So we need to advocate for early availability of vaccines, but we have also situations of conflicts, humanitarian crisis in our countries. So we need a lot of collaboration. Now, taking you to the vaccine allocations globally, the goal is to protect the public health and minimize societal and economic impact by reducing COVID-19 incidence. Now, this COVAX facility, a coalition of World Health Organization, the Gavi Alliance, and also the Coalition of Epidemic Preparedness and Innovation, the three, using UNICEF transport mechanism, supply mechanism, have put allocation of 20% of the needs of high-risk population of each country for low-income, middle-income countries inclusive. So this 20% will include 3% for front-line health workers and social care settings, while the 17% in phase 2 is targeting the elderly, more than 60 or 65, depending on the country, plus those with comorbidities, those above 18 years, but with comorbidities. So the allocation from the COVAX facility is coming only for the 20%. So our countries have to buy the vaccines beyond the 20% of their needs. So the partnership for COVAX is aiming for equity. I have already mentioned the partnership. 119 countries and territories are engaged. 98 of them are self-financing, and 92 are low and middle income countries. Without this platform, we wouldn't have had the vaccine. So that effort is already being made. The approach is to support the access. I've already explained how the 20% allocation, but even that one, we don't get it at once. It comes in phases. In Africa, 47 member states are eligible, including advanced market committed countries. Nearly, you can say that all of our countries are participating. So by mid-2021, only 3% of our population would be vaccinated. That is even very optimistic. In phase 2, to reach the 20%, maybe end 2021, depending on the vaccine doses that we will get. So this is about highlights of the COVAX facility. So moving on, I hope you enjoy our pictures. There are different vaccines also in the platform that in Africa at the moment. Now, how is it faring in our region, in Africa? You can see 43 countries have received nearly 27 million doses of different COVID-19 vaccines through the COVAX facility, bilateral deals with manufacturers, or donations, where sometimes there are countries, high-income countries, who have donated to our countries. And on the vaccine rollout, you can see in the second column, 28 countries have received 16.5 million COVAX doses. It includes different, like AstraZeneca and Pfizer. Multiple vaccines are in use. You can see the legend later on in the PowerPoint presentation, but majority are using AstraZeneca vaccine in Africa. So the progress so far is 22 countries so far have really started embarking on the vaccination in our region in Africa. So how are we prepared? How did we do the preparation? There is a coordination mechanism. The National Development Vaccine Deployment and Vaccination Plan is there, a guidance, which aligned with the strategic advisory group of experts in WHO, where they put value framework, prioritization roadmap, and fair allocation, which we are using. For the vaccination plan, each country has developed a plan, National Deployment and Vaccination Plan. They did progressive assessment to really improve on their preparation. And a regional review committee looked at those plans and then submitted to the global allocation for the vaccines. So while COVAX will give us 20% of our needs for the high-risk population, the African Union has targeted to make efforts to reach 60% of the population, of Africa population gets by mid-2022. Africa, I maybe have forgotten, is over 1.3 billion population, as you may know. So there are different financing opportunities that are also placed here. You could see the African Union through African CDC is mobilizing the banks, African World Bank as well, loans, all are like financing opportunities coming. In the WHO, we are putting a lot of effort to build the capacity of our health workers. Why the need? Because the different vaccines come with different specifications. And you may be aware, none of the vaccines so far who are approved by WHO for emergency use listing are licensed by when they are phase 3 clinical trial, not even phase 4, because we have to respond to the pandemic. Looking at their safety, efficacy data, 4 vaccines have been already given emergency use listing. But that's why we need the training. So we have prepared guidelines, micro-planning tools, intra-action review, and their field guide. In addition, we are using tabletop desktop exercises to really see a simulation sort of view for our countries before they introduce the vaccine. Another thing we are focusing is the vaccine effectiveness studies. As I have mentioned, our vaccines are released in phase 3 clinical trials. So we want to see in real world performance, how do the vaccines really work? So we are going to study, and we are selecting few countries to do vaccine effectiveness studies in the field. So far, our observations is that it's varied. Some countries have advanced in preparation with details of plans, identifying their populations, including special population. Use of more than one vaccines, you have seen. Not all countries used consent for the healthcare workers' vaccination. It is country-level decisions. And we had issues with this AstraZeneca vaccine where they thought that there was link with the blood clots. However, we needed extra communication to convince our communities that it is still the best tool that we have to prevent severe morbidity as well as mortality. So our countries are sharing their data. We need the COVAX and supporting partners really to work closely, because we don't think we'll have the vaccine as we have predicted. So the phased introduction learning is ongoing, as well as efforts to build capacity. Few challenges that I want to say, this is my last slide. Global shortage of vaccines is there. So depending on production, end 2022 or mid 2023, possibly will reach our target 60 to 70%. Those sharing by high-income countries and donation, including the government of Norway, which we really acknowledge. Few are very committed to help these poor countries that we have. Critical gap of capacity in manufacturing vaccines within Africa is a challenge, really. But our heads of states have recognized. In Africa, only 5 countries. To mention few, South Africa, Senegal, Tunisia, Morocco, and Egypt have the manufacturing capacity, at least pre-filling and so on. So we are negotiating from WHO if they can really loosen or make flexible this property right, intellectual property rights, so that African countries can also increase production or by manufacturing. The funding is a challenge, and WHO is advocating for concessional laws with zero interest if we can. So you can see we have also double challenge. When you see on the right side, the picture is showing you in the Ebola outbreak that is ongoing in Guinea on top of the pandemic. So vaccination already, we are vaccinating over 1,600. So some of the countries have conflict, internally displaced population at the same time to deal with. In conclusion, WHO calls for all efforts to be made towards vaccine equity, the equitable distribution of vaccines, really. The next is producing sufficient doses of the vaccine depends on international cooperation. Like Hilde mentioned in the beginning, some of them are going even beyond their need. And we hope they will be compassionate to help the poor countries. Significant political and financial commitments are needed urgently from governments. So this is my concluding slide. Thank you so much.
Thank you, Meseret. If you can just stop sharing. Yeah. Then Peter, go ahead.
Okay, thank you so much, Masrit, for a very nice presentation. You've talked about a lot of things, and I don't need to repeat most of those things. Excuse me. So for me, I'll just focus first of all on profiling, just mentioning a little bit about how the pandemic has evolved in Africa, then move on to talk about financing of COVID-19 and the resource gap and the fiscal challenges that African countries face, and what can we do to really move ahead in order to ensure vaccine access. And then I'll talk about some of the issues in pricing, and I'll talk about fairly whether really there is unfairness in the treatment of prices that the countries are facing, and maybe ultimately I'll talk about vaccine hesitance. So in general, we know from way back there've been concerns, concerns that Africa will suffer a huge burden of COVID-19 because of a lot of factors. And there were predictions that there will be so many deaths and all that. Up to now, that hasn't happened. Thankfully, it hasn't happened, and a lot of explanations have been provided for that. But that doesn't mean that Africa hasn't faced the burden of COVID-19. If you look at the profile of many countries, you will see that the deaths, of course, people would say that cases may be, but death is a good measure of, for at least of what the burden may be. So if you look at a country like Norway, which has recorded about 640 something deaths, currently I think about 649 deaths. So there are countries that have in Africa that have experienced more deaths. For example, Ethiopia, more than 2,600 deaths. In Zambia, about 1,000 something deaths. The same with many other countries in Southern Africa, in excess of 1,000 deaths. So those deaths are higher than some of the countries that have really done well in Europe to contain the virus. So it's not that Africa hasn't been affected. It has been affected, but of course it hasn't been affected in the way that everyone thought it would be. And this is, of course, testament to some of the measures that have been put in place, but of course other epidemiological factors that is really a discussion for another day. So in terms of the waves that we've experienced in Africa, so we experienced when this virus arrived, sometime in March when the lockdown started, Africa, there was no peak in COVID-19. I think the peak started sometime in August. That's where we saw countries in East Africa like Kenya and West Africa having high incidence. But for Southern Africa, we only saw huge increases in COVID-19 after Christmas holiday celebration. And this may have been due to maybe laxity in behaviors and protection. So in December, January, that's when we saw countries like Malawi, Zambia, Zimbabwe, they had some peaks in COVID-19, but that has since gone down. So the cases have reduced again, which is really a good thing. But as we have seen, there have been multiple spikes in COVID-19 cases, like first wave, second wave, and all that. So the fact that we've seen a reduction in COVID-19 cases shouldn't be a reason to relax measures. There is need to increase. Actually, studies have shown that there is very little adherence to measures in most African countries. Ethiopia, of course, because I work in Ethiopia, so there is a lot of literature that has demonstrated maybe less than 40% adherence to COVID-19 measures, which is a big problem. So now when it comes to impact of COVID-19 on the economy, we know that at a national level, most African countries have been affected. Revenues, government revenues have been affected such that they are receiving less money. The commodities, demand for their commodities which they export have been affected, and therefore they have less money to do anything, to provide services, to provide healthcare, and to provide all those things. And that's where I'll pick it up from when it comes to vaccine financing. It's about government capacity. Of course, at the individual level, there have been surveys that have been, and we've published a lot of studies that we've done ourselves on how individuals have been affected economically by COVID-19. Those studies show that, of course, even if incomes have been affected somehow, food security in general hasn't suffered in most countries. The World Bank has also documented that. Most countries' food security has remained stable, even in countries such as Malawi. Explanations have included the fact that adherence to COVID-19 measures haven't been very high, but also maybe the impact hasn't been very bad yet. But so we see less effect on food security at the individual level, but big impacts on incomes. Incomes have been affected, employment has been affected, but people have also gotten changed employment, and the World Bank data shows that those people who lost jobs have gained the jobs back. That's the current data that shows right now. But those jobs have been more vulnerable jobs than they had previously. So we expect these things to have bigger impacts in the future. But I think my interest is the effect on governments themselves. We need to get vaccines to people. People need to get vaccinated so that further deaths can be prevented. But what we see, for example, right now is that in Africa, for example, to vaccinate 60% of the population, Africa needs about 10 to 15 billion US dollars. 10 to 15 billion US dollars. And the COVAX arrangement, I think they've only managed to raise so far slightly less than 6 billion US dollars. The US government, I think, to the COVAX has provided about 4 billion US dollars. The UK government has provided about, I think, less than $1 billion US dollars. So there is really a gap. The COVAX system itself, it needs about 27 billion US dollars for them to meet their targets that Masret has mentioned. The first phase cover 20% of the vaccine requirements of each country, and then the second phase to move, all those, they need 27 billion US dollars. Just for your perspective, the US government, personally, and I discussed this when we had the webinar, Socioeconomic Determinants by the WHO, I've always argued that some of the amounts involved in procuring vaccines, providing food security to countries that have been most affected, these are amounts that can be covered by countries, high-income countries easily. Because if you look at what the US government provided as the package for rescue package, they provided trillions of dollars. And many other countries in Europe have spent billions of US dollars on providing even cash transfers, not vaccines, but cash transfers to people so that they can, reduce the socioeconomic impact. So $15 billion for Africa is a small amount. If people came together, if even high-income countries came together to say, okay, let's provide this. And my argument has been that it's not really on ideas of fairness or equity. It's also to the benefit of high-income countries that people in Africa and other low-income countries should get vaccinated, because this will prevent the emergence of other more resistant strains of COVID-19. If these emerge, even if Europe were and the US were to set up travel restrictions from Africa and other low-income countries, it can't be perfect. So there will still be a risk for more resistant strains. So the idea of providing financing for vaccines is not really one that can be argued only on ideas of fairness and concerns for other humans, but it's also for the benefit of high-income countries. Now, we know that the COVAX facility can only cover so much, but most countries like in Africa, they've estimated that because of the young age, most of them just need to cover about 50% of their population vaccines. They need about, most of them it's about 40 to 50%. So now, if you look at the COVID, the assured allocation about 20%. So most countries in Africa will have a deficit of about 20 to 30%. The question is, where are they going to get those resources? Already we know that they are financially constrained. They cannot raise domestic resources to purchase those vaccines. Zimbabwe recently announced that it has allocated $100 million US to the purchase of vaccines to cover about 60% of its population. That's about $100 million US. It's about a third of its total health expenditure. So if it is allocating a third of its total health expenditure on vaccines, what other services, health services, will suffer? Because it's not like they have fiscal space elsewhere. If you look at fiscal space of most countries, they are really constrained. So this will, I was listening to this person who was saying that in Zambia, for example, they stopped doing surgeries for heart disease because they transferred all the money to the COVID response. So that's what we expect. So we expect these countries to reallocate, but still they won't even be able to cover the deficit in the vaccine, in the money that is needed for vaccines. But what is worse is that we have these countries facing worse prices. African countries. So if you look at the cheapest vaccine, which is AstraZeneca, which has been provided generally at $5 per dose. Countries, Europe is paying almost slightly over $2 per dose. The US is paying about $3 per dose, and things like that. Of course, the justification is that they have invested in research and development for those, but most of it is also because of the negotiating power. So I think there is also need to rethink the ideas of the pricing of these vaccines. If they can be if for example high-income countries cannot provide these vaccines to low-income countries, but they can subsidize through the manufacturers so that low-income countries can get them at a cheaper price. We also have a situation where these vaccines, so I think probably my time has run out. Let me stop there so that I don't see that, yeah, but I'll pick it up later. Yes, thanks.
Thank you for that, Peter. There is a question that has come that I think it's good if you answer just right now. It's from Helge, and he's asking how reliable are the statistics about deaths and outbreaks in Africa? So if you could just comment shortly
Yes.
on that before we move on.
Okay, so what I can tell you after, of course, there have been studies that have shown that all-cause mortality has increased and there's even deaths. So there are some deaths that have happened and they were brought in as brought in dead. There are studies that have been shown. But what I can tell you is that the deaths is not like double what is recorded, at least for deaths. And this, what we have done also is to profile a percentage that are reporting illness. So from the World Health, or from World Food Program data, they've been collecting data on illnesses, trends in illnesses from March 2020 until now. And that trend has shown that there hasn't really been those big spikes in the proportion of people that are reporting sickness. So if there hasn't been spikes in proportion of people that are reporting sickness, then we do not expect that people have been that sick as was projected. So what I can tell you is that yes, there is those statistics, definitely they undercount deaths, but what you will see is that they are consistent across countries. So we see, for example, in all the countries like Zimbabwe, Zambia, Malawi, the number of deaths are almost similar, unless they agreed that we should report this number. But the fact that they are almost similar shows that the undercounting or the bias is consistent. It's not systematic. It's systematic. It's random. Sorry. Yeah. So I don't know. I hope that addresses the question.
Thank you for that, Peter. Go ahead, Salome.
Thank you so much also for inviting me. Really an honor to be here. And I think I'm going to take a slightly different angle from the other two speakers, because I'm going to talk really about some of the vulnerable populations, and I'm talking about COVID-19 and women's health. And my focus is going to be on a bit on equity. And this is obviously can apply some of this to other groups as well. But I think what was important was also to highlight not just what is available, but what is the situation been for other populations that might be more vulnerable. I am an obstetrician and gynecologist and head of global surgery. So my work touches on this from a global health perspective and also from a maternal health perspective. And I think the two important questions have been, what is happening to women who are not infected, and what are the outcomes of women who are infected? At the beginning of the pandemic, many of us were more concerned with what are the outcomes of women who are infected? Is there transmission from mother to child? You know, how do women do? What are the outcomes of women in general against men? And I think some of these questions have been answered with time. For example, we know that there is very little evidence that there is mother to child transmission, even though it has been proven in some cases. It's been extremely rare. And there's been evidence also about breastfeeding, and we recommend that women breastfeed even if they have COVID. But I think the more critical questions that came up, because as I said in the beginning, there was more of a fear about what happens to infected pregnant women. But with time, the question started evolving to what about those who are not infected? And so some of the things that we started seeing, at least in our country, was, you know, the fact that the pregnant women are also a source of infection. Those who are admitted to healthcare workers, to other women in the wards, you know, and coming up with better policies for PPE, better recommendations to try and ensure that, one, the women themselves are protected, two, there isn't protecting the newborn baby from infection, three, protecting other women in the hospital as well, and in these settings. But after that, I think the more pertinent questions came around what has happened to the maternal mortality rates, what has happened to the stillbirth rates during this time. And in some countries in Africa, particularly in South Africa, the maternal mortality rate last year during the lockdown period went up by as much as 30%. And so, and it's not because of the severity or the number of patients or women that died due to COVID-19. It's because of the access to care for pregnant women during that time. And so those are some of the things that have come up. Issues around contraception, women not being able to access care, and what has the messaging been? You know, have countries been consistent in telling women that continue to look for to attend antenatal clinic, continue to go for contraception, to access contraception during this time? This has not been consistent across many countries. So from a maternal health perspective, what do we know? As I've said, there have been many unknowns about pregnancy and COVID-19, but over time, more questions have been answered. And I think every day as scientists, we are learning more about the disease, we're learning more about the outcomes, and there have been better interventions to try and protect women and improve outcomes. But we do know that the risks of severe disease is higher in pregnant women. And so pregnant women are high risk for severe disease. That includes death, that includes the need for ventilation, etc. So these are serious concerns that have been highlighted by the CDC, that have been shown across the world. There's been an evolution of science related to COVID-19 and pregnancy, as I've mentioned, and the absence of clear messaging about pregnancy and reproductive health during the pandemic has also resulted in women not attending antenatal clinic or family planning clinics. And these are really serious matters that need to be addressed. So what has the effect of the pandemic been on women's health as a whole? As I've mentioned, there's been increased mortality rates and stillbirth rates in certain parts of the world. And the real damage, the real collateral damage, as some of us refer to, is really going to be known afterwards. You know, it's only now some of these trends are starting to come up, but the real impact is going to be known with time. And I think that gaps between what's been happening in high income countries and low and middle income countries is going to be clearer, especially because we started already on a back foot in many of our countries. The maternal mortality rates were at least 10 to 20 to 30 times higher in some of our low and middle income countries than they are in high income countries. And so with this gap where women haven't received the care that they were meant to receive, it also means that that has, in many countries, that also might have taken us back to a few steps in terms of improving outcomes. Reduced contraception use has been reported in some countries, South Africa particularly, reduced access to reproductive health services. And you can't blame the women because they've been fears, there've been anxieties, there've been lockdowns where women were told do not go. And so without clear messaging to say that unless you have this, you can't blame the women for staying away or for not knowing what to do. We also know about the increase in gender-based violence in many of our countries, the increased responsibilities for working women. And so whilst the lockdowns meant that, let's work from home, but for women, there's enough evidence to show that the responsibilities and homeschooling and looking after kids during this time, that has not been equitable. And then we also know that in many countries, surgery has been stopped. And so women who needed even minimal surgery, we need to catch up in many places to offer that. What does that mean for cancer patients? For example, women who have not had pap smears over the last year, some will be at increased risk of developing cervical cancer, breast cancer, where the screening has not been done. It's not safe to say that just because they were not screened or tested that they are not sick, even though there have been efforts to ensure that, those who need surgery receive surgery. But what about those who delayed and were not able to get screened because of trying to adhere to national regulations? So in conclusion, I really just want to say women merit special attention. because of their distinctive contribution to society, a contribution that is under-recognized, undervalued economically, socially, politically, and culturally. And so we shouldn't, even as we increase the number of vaccines that we provide, let us not now have a case where even the distribution is not equitable, where more men are being vaccinated than women, for example, or where there's inequity amongst the poor and the rich as we expand these programs in African countries. Thank you very much.
Thank you so much, Salome. I'll just see, we have already gotten some questions here. Yeah, I think this one can be tackled by you, Meseret. Could you say, Susanna is asking if you could say anything about if there are differences regarding vaccination in the urban area versus the rural areas. Is the started vaccination mainly in urban areas? She's thinking about the challenge regarding cold storage and the lack of infrastructure.
Thank you so much. As you know, the first targeted groups are health workers, healthcare workers, and the social workers who are upfront. So what we have done is that all the countries have listed, at least pre-listed their healthcare workers in the facilities, be it private, be it in the NGOs or in the rural areas. So they have a mechanism of reaching them. However, there are certain vaccines like the Pfizer who need ultra cold chain. That is like around -70 for storage, but they also should have special carrier mechanisms, special cooler boxes that they go to the wherever the service delivery point would be. So what they have done is countries who have, like Rwanda, for example, is where they have the ultra cold chain, they have put the Pfizer vaccine. Where they have received the AstraZeneca vaccine, where they don't have the ultra cold chain, then they would ship out that vaccine. So that type of micro details are there. So we won't say it's only in urban areas for the healthcare workers. That started at the moment.
Thank you, Meseret. Peter, Vidar Stian is asking or writing, there will be more pandemics in the future. What can be done to change the World Trade Organization patent rules, and what are African countries and regional bodies doing to enhance production capacity in general? Maybe you can start, and then Meseret, if you want to weigh in, feel free to do so.
Okay, so for me, generally the patent rules, of course, it's very important to have patents in order to encourage innovation, because if you don't have patents, companies will be hesitant to invest in the development of vaccines. So I think what the work that needs to go on right now is that we need to ascertain what is the right amount of patents that should be given. Because right now you have firms, they should be allowed to reap the profits or to recoup the investment that they put in, and then beyond that, and a certain level of profit. After that time, they should be, these patents should be, so that may require a lot of, so what can be done in short? There is need for research to ascertain what is really the optimal amount of the period that needs these patents to run in order for them to recoup, because we already have experience of vaccines in the past, so we can estimate this from past data. And then coming to the production capacity. The production capacity is, you know, now we have the Africa Union coordinating bodies that, you know, the Africa CDC and others. So there is this intra-Africa collaboration that can be put in place to even to manufacture some of these vaccines, to do all these things. But the challenge that is there is the patents like you have rightly pointed out. So they may not have money to invest in research and development, but once this has been determined, they can produce the way India produces. So I think that's really the idea. There is production capacity in many countries. In Kenya, already we know there is production capacity for many drugs. In most countries in Africa, yeah. So probably that's what I can say, Ms. Red.
Thank you. Let me compliment Peter. Definitely, like you have said, maybe a limited, like the feeling and really can be done at like in South Africa, in Senegal, even in the Northern African countries easily. So once they have made their profits, at least a certain level of patency could be flexibly released so that the fill and packaging could be done at country level. That would really increase, one, the capacity, transfer of skills would come. And so that compassionate type of thinking, we hope, beyond the business profit margin, should be there in time of pandemic where we are losing really critical mass of people. So that's the way I would approach it. But definitely there is effort also from the African Union, countries being more and more interested. Already 10 manufacturing capacity is there in the African region, in the 5 countries. So it can be speeded up. We are not saying the whole thing should be produced. It takes time, but we can start with baby steps with the filling and packaging to be done. That way, maybe we can fast track the access to vaccines. Thank you.
Thank you, Mesret. And just to follow up on that, Vidar has asked, can you speak about how quickly the countries you mentioned in Africa would be ready to start producing vaccines if the patent rights are lifted?
Okay, probably I just was sharing, I mentioned the countries, 5 countries already who have that capacity. For example, if we take Senegal, they produce the yellow fever vaccine. They are one of the 5 countries globally producing yellow fever vaccine. And it's a developing country in Africa. So it demonstrates that possibility is there. So what we are saying is in the 5 countries, Senegal, South Africa, Morocco, and Tunisia, if a transfer agreement was done with flexibility, it can be really, we can increase the production as much as possible. But we are not saying we'll start from scratch, but probably with the end product being packaged and filled at in our countries. Then through time, probably the pandemic should be ending with some good results like this for Africa. Thank you.
Thank you, Mesret. And when we are speaking about the fact that pandemics will come again after this, when you are looking at the health system, how, this is for you, Salome, how can we make sure that during a pandemic that African countries ensure that women and girls have access to these standard health services, especially for sexual and reproductive health care?
Thanks for the question. And I mean, a lot of what you know, the pandemic exposed a lot of things. I think we need to start there. And the fact that we were not ready, we were unprepared, you know, all of these things around women's health, for example, that I've mentioned, are just a reflection of partly what was happening already. You know, there were gender-based violence was there, you know, has been a problem in many places. The unmet need for women's health, for contraception, these things have been there. But what the pandemic did was put us in a place where suddenly everything had to escalated very quickly. And even the measures were not in place to start saying, what can we do? What can we do differently? How can we ensure that there's access to care whilst also making sure that the disease is not spreading and all of that? So health system strengthening is an important component of what needs to happen right now. We need to look internally within and see how can we strengthen and improve healthcare services for women as a whole, for vulnerable populations, improve equity. You know, and we have to do it concurrently with with everything else that we're doing right now, you know, and I mean, it's not a new problem, you know, per se, but on top of everything that has happened over the past year, you know, it just highlights even more why we need to pay attention to some of these things, which we're not getting enough interventions and efforts. And the health system strengthening has to happen internally, you know, even on some of the things that have been mentioned here. As Africans, we need to improve our systems. You know, it's partly, yes, let's unite as the world to try and improve problems. But as scientists in Africa, we need to rise up and start finding solutions and being innovative and driving some of these processes. Women's health, of course, I spoke about what happened, but it's also often a human's rights issue. You know, it's women's rights issue. It's how seriously do we take women in our societies when we are the continent that has some of the worst outcomes that when it comes to women's health or women's outcomes. So, you know, I don't think I'm really answering your question, but all I really feel is that we need to take seriously what needs to be done in strengthening our health systems to preparedness for future events like this, but also to strengthen the current systems and that we have.
Thank you. You speak of strengthening the systems from within. And Meseret, could you maybe say something more about, we have already heard that the vaccine distribution is not equal. African countries are paying more for the same vaccines. But what can be done within African countries? And like civil society organizations, what can they do, or what are they already doing to ensure equity in this corona pandemic?
Thank you for the question. The civil society organizations are really, they take a big role even in the service delivery. Through the NGOs, there are facilities who really provide services at operational level. Beyond that, they also have a really added value in advocacy, because their representation is high, they are listened to, they have a big voice that governments listen to. So I think partnering with the CSOs would really help us a long way to go. They can point out and freely speak independently as advisors to our governments by picking the issues transparently. So collaboration with the CSOs is very important. It can go a long way. We are working with them, but it can take us further. Thank you.
Thank you. I was wondering, in Europe and in the US, we have found increasing COVID-19 anti-vaccination movements. I was wondering, Peter, do you know if are there similar groups in African countries? And if yes, what is being done to kind of address the vaccine hesitancy across African countries?
Yes, thank you so much for that. Yeah, so we have huge anti-vaccine movements in Europe and in the US. In Africa in general, the anti-vaccine sentiments have come from religious leaders most of the time. And it has been via conspiracies to say that maybe this vaccine is like this and all that. That's really the biggest anti-vaccine movement that has come up in most of Africa. But when you look at the data, it's really surprising and interesting to see that when you look at the data, if you talk about those who say they would be willing to take the vaccine, the proportion of people saying they would be willing to take the vaccine is much higher in Africa than most countries, even Italy, for example. The surveys that have been conducted there, I was looking at this review that showed that less than 60% said they would be willing to take the vaccine. But in Africa, you have countries, in South Africa, for example, you have about 98, in Ethiopia, 98% saying they would take the vaccine. In Malawi, 83%, you know, all those are high rates of vaccine acceptance. So, but of course, some of these studies were conducted by phone surveys, so there could have been some bias, like in terms of some of the people that may be hesitant, they may not have participated. But I think what can be done in general in order to ensure maximal acceptance is really working with trusted organizations. That's where the CSOs come in, local organizations that people trust. So there is need to engage more. Religious leaders have to be engaged and informed more. Traditional leaders, community systems have to be engaged. That's the only way you would reduce vaccine hesitance. Probably that's what I would say. Yeah.
Thank you. We'll take some more questions from the audience. There is one from Atovu. I don't know who will feel comfortable answering this, but he said, why should the World Health Organization or development partners reduce the vaccine price for, I think it's supposed to be WTO, reduce the vaccine prices for African states yet when they invest more on military and prisons instead of research? Maybe you, Peter, want to address this question.
Okay, that's a very good point. But we know that every person needs a balanced diet. So, and military expenditure, of course, no one would say you should would favor military expenditure, but it's part of a diet that every country needs to have for them to have a balanced diet. They need to protect themselves from any eventuality and all that. So what is not good is when the proportion of military expenditure is above something that is acceptable. But if you look at most of these African countries, the proportion of GDP that is spent on military is far, far much lower than the countries that we are saying should be at the forefront of helping to fund COVID-19 vaccines. So I think in general, what we are saying is that military expenditure in most of these countries is not as bad. So what, of course, it would call for some effort to say, is there a need for reprioritization within the budgets, the current budgets? Is it possible, for example, just for the short period, is it possible to take away money from maybe buying more guns just for the short period? That could be a good advocacy policy for a short period, at least for 2 years, for the next 2 years in the next 2 budgets. Yeah, but in the long run, of course, they need to invest in security, national security. That's what I would say.
Thank you. We have a question from Helge again. He asks, could there be a problem with vaccines not approved by COVAX? In the Gambia, some health centers have got some vaccines, I am told, but they don't know where it comes from. Maybe some Chinese coming as a gift from Senegal. Not knowing the quality of the vaccine makes people reluctant to get vaccinated. And could it become a problem with unserious vaccine? This goes a bit back to what you talked about before, Peter, but I don't know if you and Mesrat maybe would want to say something about this. Is it likely, will we see these unserious vaccines that he calls it, and could this become a problem? Mesrat, you can start.
Thank you. Yes. Thank you so much for that question. Very interesting. Yes, you know, each country, what they have is regulation authority for medicines, drugs, including vaccines, a regulation authority, national regulatory authority. And every import of biologicals should meet the standards of the national regulatory authority. I'm not saying that we have perfect system and something will not sneak in, but the border controls should be very strict, tightened, unless there is a way of smuggling them. Because we heard on them, but the World Health Organization has empowered countries how to go about this, because it's not only for vaccines, even for drugs, we get fake drugs smuggled into the countries. where we are having antibiotics, anti-malarial, anything, name it. So it's a fight that we are prepared for, but the national regulatory authorities should really have a stringent mechanisms, stringent mechanisms. They could have bypassed somehow, we don't know. But if that evidence is there, the countries are supposed to report it, investigate it, and really put measures that they have put already. So that these unqualified, unlicensed vaccines should not get in. But it doesn't mean to say that some countries have got bilateral deals with governments, like in China, with government of India, and so on. But although India has the AstraZeneca vaccine, which is EUL, meaning emergency use listed, some of the Chinese vaccines, it was just yesterday in the SAGE meeting that they have produced their dossier, and probably under strict scientific scrutiny, they may be given authority for emergency use listing. On the same, some countries have already, their regulatory authorities have licensed for them for use. For example, in some countries, like we have shown in the maps, they are using the products from any other countries, which are outside the EUL. So that's the way I would approach it. Thank you.
Do you want to add anything, Peter?
Yeah, I think she said much, but what I would say is that, of course, the idea of, in South Africa, we saw that fake vaccines were confiscated recently, and in many other countries. So that is very common, but it's really organized corruption, organized crime. It's mostly by the high level people that this thing happens. It's a way, and that's the reason why. So for example, for us at CMI, we have an anti-corruption, U4 anti-corruption, and our anti-corruption work really has focused on how to avoid, because there's a lot of corruption that has been exposed in the COVID-19 fight. So just to see how that corruption is working, organized, and all that, and what systems have to be in place to avoid that corruption. So right now we know that as at yesterday, there were like more than 200 candidate vaccines being developed. So we know that there will be some people, especially in low-income countries, that would want to benefit from this, and they may even that 20%, we say that the COVAX will cover 20%. They will even try to convince their population that we cannot manage to pay $5 per dose from AstraZeneca, because that's the cheapest. So they will say, oh, there's a cheaper one at $1 per dose, and those will come. But some of those may be a problem, and they may be confounded in corruption. So even as we are looking at all these protecting these AstraZeneca and all that, countries should look at possible corruption that may come from candidate vaccines. Some of them may work, but procurement will be shrouded in corruption by leaders. Yeah, that's what I would say.
Thank you. I think when we are speaking of Chinese vaccines, it's a good question that has come from Lars. Some make the argument that donation of vaccines to a number of African countries, for instance from China, is a way of getting influence, the so-called vaccine diplomacy. Is so-called vaccine diplomacy a threat? And if so, what consequences could it have?
Okay, let me try, Hilde. Thank you for that question. Yes, we've seen donations of vaccines, but then we go back again to the evidence research by the National Medicines Regulatory Authority of each country. To go through the dossier, they have scientists, they have regulators who are very well trained, equipped to go through the dossier. And if they believe that is what is beneficial for their communities, you cannot say no. But what the World Health Organization has advised for only the emergency use listed vaccines to be used for now. But if that is, we can't prevent it. So yes, it may influence, that in a way, it's also looking for business, is it not so? You donate some, but maybe certain amount you would be selling to the same country. So it's also like that. Beyond the diplomacy, I think it's also looking for maybe markets. That's the way I see it. I don't know if Peter or Salome can complement. Thank you.
Yeah, I'll just add and say, I mean, this isn't business as usual. We've got a crisis right now. People need to be vaccinated. As Meseret said nicely, Africa has got 1.2 billion people, you know, under 100 million have been vaccinated. And I think that should be the focus, that, you know, let's find every means that is possible to get as many people vaccinated as possible. And, you know, and not worry as much about some of these things. Looking back at history, there've been donations from other, you know, bilateral agreements, donations for many things. This is not the first time something like this is happening. So I would say we need to focus on what needs to happen. It's about saving lives right now and preventable more unwanted deaths.
Peter, do you want to add anything? No. So
Hilde,
we'll
maybe one point, which I remember Salome was responding to, is that, you know, most of the vaccine candidates are around phase 3. So those donated vaccines, the moment they are donated in that country, it's also getting more population for your, you know, trial. This time in the field, like sort of vaccine effectiveness, you can get more data to give you confidence and so on. So there is also that kind of approach as well. Just to compliment. Thank you.
Thank you for that. There's also a question from Stian here. We're going to South Africa, Salome. South Africa is entering a third wave of corona, and Easter holidays coming up with traveling and religious gatherings. Will the current current vaccination pace be able to help the situation in the country with the most cases and deaths on the continent?
Yeah. So the answer is no. You know, I think we're nowhere close to where we want to be as a country, but already there's a lot of discussions of what can be done to prevent you know, further spread of the disease during this time, and thoughts about having further, you know, increasing the lockdown level, you know, further messaging and trying to reinforce that people don't travel, all of these things. So I think during this time, it will be back to public health measures, because we know that within the next week or two, there's no way that, you know, we can reach the level that we are looking for.
And with since the lockdowns and everything that has happened and the outbreak of COVID-19 in South Africa, there has been a huge increase in reports of domestic violence and other forms of gender-based violence. Could you say a little bit more about this and what is the situation right now?
Yeah, and I mean, as I mentioned during my talk, you know, there has definitely been increased reports of gender-based violence. The president has started a commission on gender-based violence in the country. There's funding towards trying to reduce gender-based violence during this time. So this and other initiatives, I think, and more people in women's health, and you know, there's been more advocacy, there's been more efforts to try and address some of these problems, but I think more importantly to try and protect women where it's possible, to protect them from this. It's some of it is societal issues. There are many reasons for this, but I think what it's highlighted is more the inequities that we have and the need to address some of these.
Thank you. Vidar is asking, if we continue vaccinations at the current rate, and distribution, how high do you consider the risks that a strain of the virus emerges that is resistant to the current vaccines? Meseret, maybe you can start.
Thank you. Yeah, the pace that we have, we are not happy with it, but the supply is also not there. So we have to do away with what we have by prioritizing the most at-risk groups. And even we are concerned if we continue with this pace with unpredictable assured vaccine allocation, we can't prevent the emergence of variants of concern. The longer we wait, that may be also another issue. So vaccination at the moment in Africa, we are not aiming to interrupt transmission, really. We are just aiming with the vaccine to prevent severe morbidity and mortality, really. That's where we are. We can't even talk of that. With the 3% vaccination, what can we do first? Then we think of the next 17% with the elderly and so on, just to prevent severe morbidity and mortality. But at the same time, we don't have control on spread of variants. Viruses mutate. That's their nature, by nature. And it has been tracked since the beginning of the outbreak. But the variants of concern, we just hope, will not be serious. But we don't also have the capacity to test in every single country. We have few labs in Africa, like the South African labs, where we are even transferring or transporting our samples for testing. And we don't have enough samples from each of the countries also. So sometimes we may not also be perfectly knowing what is happening within our countries, which variant is it of concern, is it not? We don't yet know. I don't know if my colleagues can complement.
Yeah, and I think, I mean, in South Africa, we had the good example that when the South African variant was picked up, the decision was made not to use the AstraZeneca and to use the Johnson & Johnson, which is what is being used now. So at least we've got some good examples that even with the changing or emerging variants, we've got some proof that, decisions can be made and interventions can be put in place. So we shouldn't be slowing down the process for that.
And in South Africa, where, like globally, most of the healthcare workforce and the frontline health service providers, they are women. And with over 60% of Africa's healthcare workforce and essential service providers being female, with numbers even reaching 91% in countries like Egypt, women are indeed in the frontline fighting the corona pandemic. But they are not that often reflected in national or global decision-making in the response to COVID-19. What are the consequences of this lack of involvement as you see it, and how can countries and international institutions ensure that women are a part of policymaking on all levels? Salome, you can go ahead.
Yeah, and it's I'm part of the Women in Global Health organization, and I think it's what is often brought up that you need gender diversity at all levels. It shouldn't, I speak a bit on teams, representation or diversity across teams. And that one is easier to have a group of ensuring that there's 50-50 or that there's equal diversity across a group that is being led or a group that's doing the work. That is easy to do. But at leadership level, where decisions are being made, where policies are being implemented, when you don't have enough representation and equity, it also means that decisions could be made that don't favor people equally. It's very similar with when you don't have enough African representation at policy level or at decision-making level, decisions that can be made that do not favor Africans or low middle income countries. So ensuring that there's diversity in leadership is extremely important. It's crucial because it means that decisions that are made will equally be favorable for various groups. And so that's what we constantly strive for.
Thank you. And speaking of some of these processes that are going on that maybe Africans are not involved in, but we have Dr. John Nkengasong, who is the head of the Africa Centers for Disease Control and Prevention. He stated that he is worried that Europe will finish vaccinations and then they will start restricting the movement from African countries to more than they are already doing. And due to Africa becoming kind of the continent of COVID. What will be the consequences of this, Peter, please?
Yes, thank you so much. No, I think we know already that that's the life course of some of these diseases. They start, first of all, like for everyone, and then they become diseases of poverty. So there is a possibility that if there is no proper support, this could become a disease of poverty and be concentrated in Africa. But like I mentioned, so there's a very likely possibility it's easy to impose travel restrictions, and that will happen because we know already that Africa, Europe plans, they'll be able to do by next year, mid next year. I know that most countries within summer, they plan to vaccinate all the elderly. So by the end of this year, they'll vaccinate a significant proportion of the population. And by next year, everyone that needs to be vaccinated will be vaccinated. But what we know now for Africa is that within this year, they won't even be able to cover. Of course, there's optimism that 20% will be covered, but it may not happen. That's even optimistic. But then the other 20, I mentioned that each country needs to cover about 50% of the population. So that the one that remains, that's even a bigger challenge because of course they could get loans from Exim Bank, from the World Bank and all that. But some of these countries are already in so much debt. And if they get these loans, there are implications and all that. So they may not be able to vaccinate their populations to get to an acceptable level within the next 2 years from the way I look at things. And there will be travel restrictions, there will be COVID-19, but the restrictions that I foresee coming in would be where you have to show a COVID-19 vaccination certificate. And of course, those people who will be able to travel, who are able to travel, they'll be able to access vaccines. So there will be inequality in the distribution of vaccines within countries. So within Africa, we'll see higher income people being vaccinated because whatever methods they'll use, but they'll be vaccinated and they'll be able to travel. Just like, of course, we've seen the way it happened with yellow fever and all that. Yellow fever vaccine, in some countries, it was very expensive. But those who were supposed to travel had the capacity to pay for it and to travel. Yeah.
Thank you. Does anyone else want to add in on that? Okay, then there's actually our last question here. It's from Marta. And this is, I guess it goes to you, Maseret. Which organizations are doing a good job in lobbying to get this patent flexibility and you would recommend we support?
Okay, thank you. I know that the World Health Organization is really trying at the highest level with all the partners concerned, including the Gavi Alliance as well. There is a discussion, and also the other partners, the CEPI, the Center for Epidemic Preparedness and Innovations. And also there is also effort beyond that. There is effort also to go for the COVAX facility beyond the 20% allocation. So there is that optimism. They really want to continue. Hopefully to be able to mobilize resources also from the other countries. So, but the WHO is spearheading this. So if they can really complement with the effort of WHO, I think that we will get an added voice. to influence this.
Thank you. Does anyone else want to add something? No. So I think if there are no more questions from the audience, I'll just, my last question to all of you that can take some minutes each to reflect on is something we have already talked quite a lot about, but what are the or will be the global consequences of vaccines not being distributed equitably based on the population size of each country, and also making sure that African countries gets the vaccines in a timely manner. So if each of you could just share your reflections on that. Maybe we start with you, Peter.
Yeah, I think for me, I've already stated one of the consequences, and it will be the development of resistant strains. And even with travel restrictions, you may not prevent from exporting. And if we talk about COVID-19 being this infectious, even if you vaccinate your population in the UK, but there are 3 people that bring in these resistant strains, we have another thing that happened with this. So all your investment in the vaccines, in vaccinating the whole population is gone. And that's why it's very important that for vaccine, there shouldn't be vaccine nationalism. It should be a global effort. We call it a global public good. This is a global public good which should be financed by everyone, because the benefit of vaccinating somebody in South America, in Africa, won't just be the benefit to them, but it will be a benefit to the whole world. That's what I would say.
Thank you. Salome.
Yeah. Thanks. I think over, the past 2 decades, really, we've spoken about universal health coverage, sustainable development goals, leaving no one behind. And this is an opportunity for us to really ensure that no one is left behind. We've all seen the worst consequences of the pandemic. We've all, lost families, friends, colleagues, people that were close to us during this time. And if nothing is done, this is going to continue to happen. And so I think it's a moral obligation, really, for the world to make sure that no one is left behind.
Thank you. Masarat.
Thank you. I think we need all the collective efforts at hand. We are interdependent. We need to believe that. You can't build a wall and prevent continents, really. And we need each other, I believe. And from the aspect of human rights and from the global targets that Salome mentioned, the SDGs, are we just talking them? You are part of us, and all of us are signing those declarations only to realize the reality is different. I think that will take us to another route. And in fairness, in human rights principle, it's not ethical to leave certain group of population not benefiting from a global good. So that's how would I put it. But then in basic epidemiology, we say impact is seen, at least it will take you to 2-3 years to see impact, even 3 to 5 years. So we are just seeing the early effects. I'm always careful to use the impact of COVID, not now, the pandemic. We are going to see, because economies are affected, health is affected, everyone, health, not only COVID-19, mental health stress, the respect of this physical distancing and just being compounded in certain space. We are going to harvest a lot of its effects as we go along. We are going to uncover. So I don't believe it's fair, and the world is interdependent. So that's why we need each other, and we need to be supporting each other.
Thank you. Thank you all for joining this webinar. Those of you who have attended and also sent in very good questions for the panel. And thank you to Peter and Salome and Masarat for your very valuable and important reflections. We have recorded this webinar, so we'll share it on our page for others to see who could not be here today. And for you, those of you who have attended, if you like the event, you can follow us on Facebook, and then you'll get notification about our next event. I would like to close with the words of Kenyan author and activist Nanjala Nyabula from a piece she wrote just 2 days ago in The Nation. And it sums up what you guys just said. And she writes, but ours are not a demand for pity. We are demanding justice. For one, the science affirms that without a global vaccination strategy, it doesn't matter how many doses Western countries hide away. This disease will not go away, and many will die. A study by the Global Vaccines Alliance found that if 80% effective vaccines were distributed equitably based on the population size of each country, 61% of global deaths would be prevented. The best way to save millions of lives around the world is to distribute vaccines fairly. And I think with those words, I wish you all a good evening, and thank you for joining.
Thank you. Thank you for having us. Wonderful.